Welcome to Voices of Change, a podcast for the Get the Medications Right Institute. We are on the cusp of a new era of specialty medications and gene therapies that will transform care. But we are also seeing tremendous waste. Annually, over $528 billion is wasted, and 275,000 lives are lost due to non-optimized medication use. Misuse, overuse, or underuse of medication therapy can lead to treatment failure, a new medical problem, or both. Consider some of these statistics. 1 in 10 Americans take 5 or more prescription drugs. More than 75% of all physician office visits result in a prescription for medication. Annually, more than 4 billion prescriptions are filled in U.S. pharmacies, and 50 to 75% of patients do not take their medications as directed. But there is good news. There are opportunities to control the loss and waste, whether you are involved in receiving, paying for, or delivering care. Living in a world where patients get the right medications the first time is attainable. The GTMRX Institute is working to educate employers as health plan sponsors about a better way to manage medications. We released an employer toolkit that outlines 7 steps employers as health plan sponsors can take to decrease waste and ensure value from dollars spent on the drug benefit by making CMM an integral part of the employee health benefit strategy. These include learning more about CMM to inform discussions with your current vendors, talking to your medical carriers, health plans, and PBMs, asking them to share their strategies and new product and service solutions designed to optimize medication use, collecting the right data, gaining leadership support for a new way to monitor, manage, and optimize medications, engaging brokers and consultants to go beyond formulary management, using your contract authority to demand a better way to manage medications, building primary care and other stakeholder alliances. This is what we're working toward at the Get the Medications Right Institute. And here's your host for Voices of Change, the Executive Director and Co-founder of the Institute, Katie Capps.
Hello, everyone, and thanks for joining us today. On today's episode, we will be talking to Karthik Ganesh, CEO at EmpiRx Health, an innovative value-based PBM with a clinically focused and tech-enabled approach to bending the RX cost curve. Karthik is passionate about maximizing value on behalf of EmpiRx clients, while also creating a corporate culture of belonging that embraces new ideas and deliberate approaches to tackling key healthcare challenges. Applying these leadership principles, he has built EmpiRx Health into an Inc. 5000 company and certified Great Place to Work organization, with 95 clients to include Taft-Hartley plans. For 7 years, EmpiRx has worked to create a better way to manage medications. We are delighted to have him on our show today. Welcome to the show, Karthik.
Thank you.
Now, I want to have a discussion with you today about today's PBMs or pharmacy benefit management programs. But before we do that, we want to learn a little bit more about you. What inspired you to take on a leadership role with EmpiRx?
Thank you for the question, Katie. I've had the privilege over the years of really looking at healthcare from a number of different angles. I've done PBM, but I've spent the bulk of my career really on the health plan and the medical side of the house, consulting, TPAs, health plans, value-based care organizations, accountable care organizations. So I've spent really the bulk of my career outside of PBM rather than inside of it. I worked for one of the big 3 PBMs a really long time ago, and I promised myself I would never do PBM again because I'm passionate about changing healthcare, not as passionate about working for a retail organization. What was interesting to me prior to joining EmpiRx was I'd spent about 8 years in the value-based care enablement space, including as a chief operating officer for a large provider-sponsored health plan. And what continued to amaze me was the fact that value-based care was finally a sign that the industry was moving to healthcare done right. Yet value-based care had 2 very distinct implications to it, the way we were handling it. One, was the value-based care has become about payers holding providers accountable, but no one's holding the payer accountable, which was definitely a concern. The second is you take the governmental business out of the mix and you take the commercial space. Employers pick up 80% of the healthcare tab in this country. Yet employers fundamentally do not understand the importance of value-based care. This has continued to be a healthcare insider story. So for a person who said he wouldn't do PBM again, when I talked with the founder of EmpiRx the first time, what amazed me was a person with the vision or the desire to build an organization, a PBM that was clinical first, and with a strong willingness to build that financial alignment by taking downside risk. So when I had my first conversation with the EmpiRx founder, the voice that kept resonating in my head was the opportunity to build the industry's first value-based PBM. And that really was the most exciting thing for me and the reason I came on to EmpiRx. It's been an amazing journey and continues to be one in terms of what we've been able to do to both innovate and disrupt this market.
Well, clearly you've been at this for 7 years and you certainly have applied a model that's resonated with a number of clients, with over 95 clients that you are serving right now. And I certainly agree with your philosophy around the value-based care and a real understanding of value-based care. I think we have a lot of work to do to educate employers about the interrelatedness between cost and quality and the value of quality measurements in order to ensure outcomes. Now, you have built something, as you said, that you were not interested in going back to this model unless you could do it in a whole different way. Can you tell our listeners a little bit about how traditional pharmacy benefit managers have failed employers, and what do you think should be the new value prop of PBMs as we move forward into the future?
Absolutely. I want to lay out a couple of key metrics that are key performance indicators that really showcase what the traditional, and when I say traditional in this case, I'm lumping traditional and transparent PBMs all into the same bucket. So what the conventional volume-based PBM model, which is quite frankly everybody else in the industry not named EmpiRx Health, has driven results that include the following, right? They have contributed to the fact that 25% of all healthcare in this country is considered waste. I mean, healthcare economists continue to call this out. On $4 trillion of healthcare spent, almost $1 trillion is waste. At this point in time, 40% of Americans have comorbidities and are on multiple drugs. A recent study said that American adults between the ages of 40 and 69, 22.4% of them are on 5 or more drugs at the exact same time. So just think about that. This volume-based model that has permeated the PBM space. It's permeated the health plan space as well, but it's permeated the PBM space, has really become about pumping more and more medications into the market. And the results have been astounding. Now you take that just purely from the standpoint of the volume game, and then you overlay it with this very distinct condition orientation that has also permeated the market, right? I mean, ever since we lost HMOs, and you think back to the HMOs going away in the early 90s and all the changes that came with that, whether we liked the HMOs going away or not, and we had strong feelings about it one way or the other, here's what the HMO model did do for us. We were guaranteed a quarterback of our care. The PCP needed to be at the center of the healthcare conversation, and as a result, knew what was going on from a whole person standpoint. This condition orientation that we have embraced over the last 30 plus years, a program for diabetes, a program for MS, a program for CHF, that hasn't worked either. And that has, again, been a part of the PBM space, right? A clinical program based on the conditions only allows you to tackle the most dominant condition. It does not allow you to go after all of the comorbidities that drive a very different level of clinical and financial risk. So a combination of the volume-based model, more drugs equals better healthcare, which all of us know is not true, in tandem with the condition orientation, has created a PBM industry that has for all practical purposes, behaved like retail. And it's an industry that is now, PBMs, pharmacy benefits are now 28% plus of an employer's healthcare pocketbook. Yet the benefit and the players in the market who have been servicing this benefit continue to behave like they're in retail. It's become about rebates and discounts on a spreadsheet, which is an arbitrary way of looking at value. Of late, it's become about drug pricing models because everyone's got a new flavor of why AWP doesn't work. But we haven't zeroed in on healthcare done right. What's in your pharmacy basket? What is the right mix of drugs? When you or I, Katie, let's say we had a household budget and we blew past it. Healthcare Economics 101 requires us to not ask the question, well, did we spend more on something? The first question we would ask ourselves would be, well, what did we spend money on? And that's the fundamental difference. You look at the entire market that's volume oriented. The question and the drug pricing fixation in the market right now, the question being asked is how much are we spending on drugs? The question that EmpiRx has challenged the market with is what's in your pharmacy basket? EmpiRx Health sees itself as being responsible in terms of being consultative with the benefit consultant, the employer, the labor union in helping their populations understand and optimize the mix of drugs that's in their pharmacy basket. And we have had astounding results just by managing waste and maximizing the optimization opportunities.
Yeah, and I can't agree with you more in terms of the fact that we're going off the rails from a current management of as we say at the Institute, we're managing the pill and not the process of care.
Exactly right.
And as you have said, we're also focusing too much on the therapeutic area at the expense of managing the whole person from a person-centered standpoint. You're probably familiar because much of what you have outlined, I think we have found within the Institute, two of the distinguished fellows of the Get the Medications Right Institute published a paper in 2018. And in that paper, they outlined the cost of prescription drug-related morbidity and mortality and found that actually they put a price to this. They found that $528 billion a year goes toward non-optimized medication use. And they called for, in that paper, a more comprehensive, integrated approach and person-centered approach to medication management called CMM. Because as you know, we keep managing the pieces instead of the whole. And certainly the move toward value-based payment is an opportunity to correct that. So I couldn't agree more with you. There's a lot of discussion today about employers, particularly dissatisfaction with their pharmacy benefit managers. We've carved out pharmacy benefits management. We've carved out mental health services, and employers today are scratching their heads and saying, wait a minute, you are not managing this benefit on behalf of my organization or my beneficiaries or my employees. What does that mean? In terms of your interaction, and I know you've had many interactions with employers today. Tell us what you're hearing from employers as you both socialize and meet with them across the country about the activities that they are dissatisfied with and some of the myths that have been brought forward as it relates to traditional or, as you said, conventional volume-based PBMs.
Thanks, Katie. I mean, and this is, I feel, the most important part of this conversation. Employers fundamentally, again, picking up 80% of the commercial healthcare tab in this country, they need to have their voices heard, they need to speak louder, and they need to demand better.
As Karthik mentions, employers pay a large portion of the cost of total health benefits for their employees. Managing this spend is essential. Whether managing the pharmacy benefit and the medical spend, ample evidence supports that CMM reduces waste on several fronts, decreasing unnecessary hospitalizations, ER visits, and long-term care admissions by aggressively managing medication therapy problems and addressing medication disasters. Evidence shows that the financial ROI for CMM programs average around 3-to-1 to 5-to-1 and can be as high as 12 to 1, resulting in a reduction in the direct mean medical cost of between $1,200 and $1,872 per patient per year, according to a study from Robert J. Cipolle, Linda M. Strand, and Peter C. Morley, entitled Pharmaceutical Care Practice, the Patient-Centered Approach to Medication Management. Let's get back to the show.
What I continue to hear from employers is the fact, again, that they feel like these pharmacy benefit conversations, they put these RFPs out there, the RFPs come back, people have put these spreadsheets together with rebates and discount numbers on the table. It all looks great, get into the actual plan performance, and spend has gone up. And the question is, and they're frustrated with it. And the best analogy I can come up with, and as you can tell, I love analogies because, we have unnecessarily complicated pharmacy benefits as a country. It comes back to retail all over again. I'm a huge fan of a Costco. Let's say I had $500. I walked into my local Target store. $500 is my budget every month. I walked into my local Target store. I knew exactly what my list was of household goods for the month. I walked in, I hit the specific aisles. I picked up the products I needed, and I walked out the door. I spent $500. Predictable. That's great. Now they opened a Costco, right? And I love Costco, but I went in and I got all the stuff at a discount, and I ended up buying a beach chair in the middle of winter. And I came back spending $1,000 for the month. I got it all at a huge discount, but I just doubled my household spend. And that's the frustrating component for employers. No one is coaching them towards the fact that this is healthcare. This is where they need to be focused on clinically appropriate yet lowest cost. The comment that I heard from a chief people officer, one of her clients, will always resonate with me. She said, Karthik, I feel like when my benefits team and I are making these decisions, I feel like there's two little voices on either shoulder. One's telling us, hey, the spreadsheet looks pretty good and you got to take the lowest cost because they're spreadsheeting differently. But the other one says, you can't forget that the conversation here is about your employees and their families, and that includes you as well. The first time you realized you picked the wrong PBM because they, on a spreadsheet, offered higher rebatability, but were still not clinically appropriate, that first time you realized that can't be when it impacts your family member. And that's the frustrating component for employers today. They continue to have these healthcare conversations diluted by retail speak. And I believe now is the time, especially coming out of the last 2 years of COVID, and hopefully we are coming out of this thing. It's time for employers to stand up, take a stand, and say, enough. We can't wait for change. It's now.
I think you make a very good point there. And I think that unfortunately, there are a lot of employers that are risk averse and they will respond to what they see in front of them because it's been very difficult for them to recognize that you can move beyond managing the pill or the discounts on the pill and move into really an opportunity to evaluate and just ask that one simple question. Is this the right medication or combination of medications for my employee or the beneficiary? That's a much more difficult conversation to have, but much more important conversation to have.
That's exactly right, Katie. You know what's interesting, Katie, if I may for a second there, is while employers have been more challenged with this, what we have found is labor unions and Taft-Hartley plans especially having a very distinct appetite to bend the cost curve very differently than what has traditionally been looked at as the way to do it. We're finding unions as being champions of innovation more so than the employer community, which is brilliant. These are folks who are running America, and it's a brilliant way for them to really take care of their members very differently.
So let's talk a little bit about that. Our listeners would love to hear your insights on characteristics of a high-performing PBM, and in what way that would support an employer health benefit strategy and their desire to manage total cost of care. And you can use an example with the Taft-Hartley plans that you're working with that I think that would offer. This is a real opportunity to educate our employer listeners as well.
Absolutely. And I will take both a Taft-Hartley and an employer perspective to it. There are some things that should absolutely be the cornerstone of healthcare. And I believe the most important aspect of healthcare has to be access. Coming out of the last 2 years, 40% of American counties, which about approximately 41 million Americans, reside in pharmacy deserts, where they are at least 15 minutes away from the closest pharmacy. You talk about health equity. There's a health equity issue for you. Broad access. And when I say access here, and employers and Taft-Hartley plans demanding access, and this is what they expect from us, this should be a broad network and it should be an open formulary. 78% of our book today is on an open formulary. 100% of our Taft-Hartley clients are on an open formulary today.
And for those of our listeners that might not understand the nuances of that, could you just briefly explain that?
Absolutely. So what you have PBMs doing is they tell an employer, or tell a plan sponsor, employer or union, that here's the exclusionary here's the restricted basket of drugs, if you will, or here's the restricted formulary that is going to be made available to your employees, and you have to pick within this. They're essentially, even before anything else is discussed, they have restricted the access of employees or members to a whole broader suite of pharmaceutical products that are out there. And they do this primarily, they call it, the excuse that's provided by PBMs is, well, by really having a smaller basket, we are containing your costs. They have created, by virtue of doing that, they have created this very artificial dichotomy between cost and access. You want better costs, you got to restrict access. Access has to be the cornerstone of healthcare done right. So again, 78% of our clients today are sitting on an open formulary, as in there's no access. The physician can prescribe whatever the member needs. Now, what we have done differently with that is we have created, by virtue of population health management, we use the Johns Hopkins ACG model. We create a risk profile. We really tailor the care to the whole person. And then we have our pharmacists working with physicians to switch prescriptions to something that's more cost effective yet clinically appropriate. But by tailoring care and really making sure it's not a one size fits all, we're able to take what would be a wide open formulary or wide open basket of drugs and really work with the physician to steer towards the most cost effective yet clinically appropriate answer. So what that does is the patient does not feel claustrophobic, does not feel jammed up from an access standpoint, yet the person who controls the pen, the physician or the prescriber, is the one who at the end of the day is now steering the patient towards the most clinically appropriate and cost-effective care.
I like your use of the pen. Many years ago, when I was on the board of the National Business Coalition on Health, there was an initiative called the Two Pens Project. And that was the two entities that basically have control over the pen: the employer as health plan sponsor who signs the check, and the physician who signs the order or the prescription. So I think that's a very good comparison.
I love it, Katie. The two pen construct is perfect. That's exactly right. So the hallmarks of the right PBM answer: broad access, tailored care, guaranteed savings, a pay-for-performance model. When the employer or the Taft-Hartley fund loses because they're spending more money, the PBM should not win. There needs to be clear financial alignment between the PBM and the plan sponsor. You win, I win. If you win more, I win more. But if you lose, I lose. So tailored care, broad access, guaranteed savings, and then a very deliberate push towards improved health outcomes. Those are in my mind, the four pillars that have to be basic qualifications of a PBM done right. And we've got all kinds of examples, Katie. I mean, we've got employers who've come to us with 12, 18% spend, some very significant consumer product companies that have come to us, school districts that have come to us. It's incredible. They've come with 12, 15, 18% trend year over year, and they've just hit a wall with us. The other thing, the other misnomer that PBMs propagate in the market is, well, our trend is under 3%. But you read the fine print, they've excluded about 20 therapeutic categories as a result of that. You take it all in, plan sponsors are experiencing significantly higher spend than the 2 or 3% that shows up on trend reports. They hit us. Our conversations with them are not about financial gymnastics. It is, what's your PMPM at the end of the day? How did the savings actually manifest in your pocketbook? If it didn't, we didn't do our jobs.
Yeah. And the three pillars that you outlined, broad access, which I like to call the formulary sometimes for those that don't really understand how traditional or conventional PBMs work, the drug menu. It's how many items are on the menu in one formulary versus how many items are on the menu, or can you tailor that? And then tailored care, and then guaranteed savings. Those are certainly topic areas that employers should be prepared for and engage their PBMs with. I want to talk to you a little bit more about tailored care, because I think this concept is both important and helps differentiate what you do. But before that, I want to step back a little bit and mention some of the overriding focus of the Get the Medications Right Institute. And that's, we believe that if a conventional PBM does look at managing medication therapy problems, which are basically, that's a care delivery issue, they've traditionally only focused on adherence, and sometimes we question why there is such a focus on adherence and not the other areas of medication therapy problems like inadequate therapy or adverse reactions or even unnecessary therapy. Does this person even need to be on this medication? Is it achieving clinical goals of therapy, or medications where the dose is too high? When you talk about tailored care, can you explain to our listeners just a bit more about what you mean about tailored care?
Absolutely, Katie. And the things you just called out are so spot on, because what you essentially outlined is exactly our view of the world. Health equity, when we hear the words health equity, which continues to take on a larger than life connotation in healthcare conversations today, the immediate thinking is, well, is the conversation really about racial inequity, or is it really about, financial inequity, or is it a conversation about urban versus rural? No, exactly what you called out. Inappropriate care, or more specifically, care that is not looking at the whole person health, care that is unnecessarily fixated on adherence or unnecessarily fixated on the most dominant condition, is creating underserved populations within every single employer and Taft-Hartley Fund's population. An underserved population and health inequity is not a concept that is foreign to every single employer. Doesn't matter how rich the employer's benefits are. And that is a fundamental thing that every employer and Taft-Hartley Fund needs to understand. We have spent way too many years, again, as a country, sitting with these condition-oriented programs, a program for diabetes, a program for MS. They have not worked. We have not seen the cost curve bending. We have not seen improved outcomes. There was a fascinating graph I looked at the other day, and I know we see these numbers. We've heard these numbers thrown out all the time. From a per capita expenditure standpoint, we are one of the highest in the world on healthcare. Yet our life expectancy is akin to a developing country. There is something fundamentally wrong with the way we've been approaching care management as a country. And by virtue of going down this condition-oriented path, and we continue to make it, we continue to bring to life Einstein's definition of insanity, doing the same thing over and over again and expecting a different outcome. Tailored care, and no more important than now, as we're coming out of COVID, right? Tailored care is about understanding the whole person. It starts with understanding the population. You have to start with the population's health. So today in our world, let me tell you exactly how we look at a population at EmpiRx Health. Every single client of ours has a very unique client clinical strategy, because we understand that you could be in the exact same industry but in a different part of the country, and you could have a completely different socioeconomic composition. You could have a completely different set of comorbidities that exist as a part of your population. There is no one size fits all. So every single client of ours on a nightly basis, we completely risk profile that client using the Johns Hopkins model. We look at clinical risk, we look at financial risk based on the utilization and the health of that population. We take that, we then drill it down to really understand, as a part of that tailoring, what's going on at the individual patient level. What is the most dominant condition based on the RX or the diagnosis code? What are the comorbidities that are a part of that? All of that gets factored into the risk profile. So based on the clinical and the financial risk profile, in tandem with predictive modeling, if a person's got a whole host of comorbidities, maybe the risk profile might be X right now, but it might be Y 6 months from now. Care management done right cannot be a one size fits all. You can't say just because it worked somewhere else, I'm going to make it work across the board. A diabetes management program, Katie, you could be a diabetic, I could be a diabetic, and maybe I have a whole host of other comorbidities. The virus that, as we're coming out of this, clearly taught us, because I have comorbidities and you don't, just because we're both diabetics doesn't mean the virus treated us both equally.
Oh, I agree.
It looked at me very differently. So understanding what else is going on with me becomes core to engaging the physician or the prescriber and having a conversation about my care regimen and the medications I need to be on.
Yeah, I agree with you wholeheartedly. And I think, as you said, it is important, particularly when you're looking at engaging with employers, to take their entire population and identify patients that have not achieved clinical goals of therapy or may have comorbidities that have an impact, and evaluating the combination of medications that they are on. I think there's real opportunity as we move forward to also add diagnostics to that mix as well, that give us insight into how individuals might metabolize their medications as you look at that tailored approach.
100%.
I think these insights are very important. And I think as we guide and educate employers as we move forward to really think beyond the management of the pill and the formulary management and drug discounts and rebates, what do you believe PBMs should do to integrate services around medication therapy management to move beyond that? And you've given us some examples of that, but this takes us into a discussion around some of the guaranteed savings, because clearly you believe in this so passionately that you structure your business model in a way that you offer guaranteed savings. So can you give us some examples of how you have effectively done that on behalf of those that you have worked with to bring about this new paradigm as it relates to how your customers should consider their PBMs?
Absolutely. The most important construct for us as we've designed how we approach anything clinically is that the concept I just shared with you, Katie, which is there are underserved populations in every single employer and Taft-Hartley plan's population. And it becomes vitally important that those underserved populations are served well, because at the end of the day, that's where you see the greatest drivers of inappropriate clinical outcomes and financial outcomes showing up, right? So the way we have really tailored it is, versus having a multitude of clinical programs, we have one program. We do population health management. Population health management for us includes the fact that every single one of our clients gets a tailored clinical strategy. So upfront, when we are estimating savings, what we do is we are buying benchmarks today. So we're servicing all self-insured plan sponsors today, but we are buying benchmarks from fully insured plans. So on a monthly basis, we purchase benchmarks from highly managed plans, Medicare, Medicaid, the Kaisers of the world, because you and I both know when it's our own money on the line, we have a different level of urgency and passion around controlling costs and driving better outcomes. Right? So we purchase those highly managed benchmarks. So when a client opportunity comes into us, we're bumping up the utilization against those benchmarks because we hold ourselves to the standards associated with those highly managed benchmarks. We're able to estimate savings up front. And then from that point onwards, once the client is on board, they get a tailored clinical strategy, population health, We are risk profiling their specific population, both clinically and financially. We're identifying, based on our own artificial intelligence, we're identifying the patients who really need, who've got the greatest opportunity for both care and cost improvement. Our pharmacists, we expect and our pharmacists to perform at the top of their license. Pharmacists should not be engaged in administrative activities. And that's what we've done with our pharmacists. We allow our pharmacists and we embrace the fact that our pharmacists behave like clinicians because they are connecting directly with physicians on a one-on-one basis, conducting peer-to-peer conversations and driving behavior change, driving therapy optimizations. And then by virtue of that, we're able to drive a very differentiated set of financial outcomes. What we've also done is we've embraced the fact that you need to have the right pharmacogenomics partner in the mix as well. So it's not just about getting from drug A to drug B because drug B is clinically appropriate and more cost effective. What if drug B, exactly to your earlier point, metabolized differently? So we've got our pharmacogenomics partner at the table as well to help figure out if drug B is truly appropriate or maybe drug C was more appropriate. So we've introduced pharmacogenomics where appropriate, but the bulk of what we've done has been really taking a very deliberate approach to population health management and treating the cause, not the symptom, treating the whole person, not the condition, treating the population, not the pill.
Here, Karthik discusses utilizing pharmacogenomics, or PGX, in medication management services. PGX is the study of how a person's genetic makeup determines their responses to specific medications. As a diagnostic tool used to support comprehensive medication management, it allows clinicians to choose a drug that is more likely to work for an individual, avoid those that might have serious side effects, adjust the dosage, or determine that close monitoring of the patient is needed. This can increase the likelihood that a medication will work as intended, reduce the chances of adverse reactions, and target correct therapies. Simply put, PGX plus CMM has been shown to improve the quality of patient care and reduce the overall cost of care. Now, let's continue to listen.
Well, we applaud you for the innovative approach. And as you know, at the Get the Medications Right Institute, we strongly believe that that type of systematic approach to medications where physicians and pharmacists ensure that medications, and that's medications, whether they're prescription or non-prescription,
right,
or alternative or vitamins and nutritional supplements, are basically assessed to determine that each medication is appropriate for the patient and effective for the medical condition, and then safe. And you've mentioned this, given the comorbidities and other medications being taken, and then able to be taken by the patient as intended. And I think you mentioned that is certainly the work of your clinical pharmacist, and clearly your clinical pharmacists are working in a patient care role.
That's right.
And in collaboration with the physicians to ensure that happens. We could speak for another 30 minutes, I think, on your ideas and the recognition that we need a better way to manage medications. And I am delighted that I've had this opportunity to talk to you today. I want to give you an opportunity to offer a final word to our listeners and your view of things moving forward.
Thank you, Katie. I really would like to wrap up with two very specific things. One, pharmacy benefits are a healthcare benefit. To your listeners, if you're an employer, if you're a union, anyone who's listening who has the ability to drive benefit decisions, please, please, please treat the pharmacy benefit as a healthcare benefit. Anyone who tells you that pharmacy benefits need to be addressed by the insiders and it's too complicated, please don't believe them. Pharmacy benefits are as personal to you as any other healthcare benefit, you and your employees and their families as any other healthcare benefit that you're putting out there. So please take the time to really embrace the fact that pharmacy benefits done right has to start with care, and you can use appropriate care as your tool to drive the kinds of financial outcomes you expect and deserve as an employer and a Taft-Hartley fund. That's the first thing. And the second, if we didn't realize the fact that the cost curve was out of control, I'm not talking about the pricing curve, I'm talking about the cost curve. If we didn't realize that the cost curve was out of control and that our healthcare system and the healthcare benefits ecosystem needed dramatic improvement over, the last X number of years, I'm hoping the last 2 years have shown us that we can't wait anymore. We have to change our thinking and our purchasing paradigm right now. Employers, funds, if you pick up again on the non-governmental side of the industry, you're picking up 80% of the healthcare spend today. Pharmacy is now bumping up to 30% of your pocketbook. Demand more now. Thank you.
Well, thank you so much. And a point that I was going to make earlier, and you just, I think, queued me up to say this, is that 80% of the way we treat and prevent illness is through medications. The fact that we carve the pharmacy benefit management strategy or management out of our total benefits is amazing. So thank you for offering that word of advice to our listeners.
Thank you.
And thank you again, Karthik, for taking the time to speak with us today and offering your insight and perspective. Thank you very much for supporting the important work of the Get the Medications Right Institute.
Thanks, Katie.
Thank you.
That marks the end of this episode of Voices of Change. Thanks to our listeners for tuning in. To learn more about what you can do to help get the medications right, please visit us at www.gtmr.org. Until next time, be well. EmpiRx is a strategic partner of the GTMRX Institute, and their support is crucial to the work we do. As a 501c4 nonprofit, GTMRX relies on financial support from those who share our mission and vision. We would like to thank the organizations who have already pledged their support to our work. These organizations include our founding funders, the American Society of Health System Pharmacists, Johnson & Johnson, and the American College of Clinical Pharmacy. Our executive members, California Chronic Care Coalition, Kaiser Permanente, Tabula Rasa Healthcare, Tria Health, and the Department of Veterans Affairs. And our strategic partners, AbbVie, the American Association of Colleges of Pharmacy, Amgen, Association for Accessible Medicines, Avera, Breast Cancer Index, Cleveland Clinic, Curator, EmpiRx, Genentech, Genomind, the Journal of Precision Medicine, Kimber Booth, LabCorp, the National Alliance of Healthcare Purchaser Coalitions, One Ohm, the Partners in Care Foundation, FACT-MI, and the Teachers Retirement System of Kentucky. Their support is essential to advancing CMM